services. We were tasked to do this needs assessment per a HRSA grant that we get that funds our primary care office. However, our goal is to make this needs assessment not just something that we checked off our list that we did. We want to make meaningful use of this needs assessment. So as you listen to the presentation, if you think of any ways where your teams could collaborate with ours, or even any suggestions for future needs assessments, we're really receptive to those. And with that, I will hand it over to Miguelina and Juliet, who will give the presentation.
Good morning, everyone. My name is Miguelina Carrella, and I work with the Shelter Designation process at the Michigan Department of Health. As Amber mentioned, as part of the primary care office grant managed by our office, we conducted the primary care needs assessment, which does a county level analysis of social determinants of health in Michigan and also health outcomes in the state. We highlighted some of the high need indicators in the state, and also conducted a statewide analysis ranking the 83 states in counties in the state from higher to lowest need. And Juliet, you can start the presentation.
Sure. Do you mind advancing to slide number 2? So this slide, you can show that our primary care office, we have a couple different program areas that we're responsible for. The statewide primary care needs assessment is a part of it, but we also work with provider recruitment and retention, access to primary care, and health planning, which all of these kind of interconnect, and we're hoping that the statewide primary care needs assessment can kind of guide us in all of those areas. Next slide. So we identified areas of high need for our health issues across Michigan. And then we took all of those needs and we condensed them down to give a good report that can hopefully help us and others as well as highlight disparities to kind of guide us. Next slide. So our indicators, we chose over 50 of them, which was a lot, but how we chose them was by looking at data availability. So not all counties report the same things. We had to make sure they were available at that level, as well as full state and national comparison. Some of those indicators and data sets we already have available. We already collect them. Miguelina does for shortage designations, and they're federally understood that they're acceptable. We also took into account any priorities that MDHHS already has, such as maternal and infant health. We made sure we got data sets for all of those as well. After we got our data for each of these health indicators, we established categories that they fit into and made sure that each county was noted, whether it was rural or urban. That kind of gave us an idea of what was going on in those different areas. We compiled the data. We then used analysis, Z-scores, GIS, which is mapping data, and statistical analysis to rank the needs for each county, and we rank them greatest to lowest need. In order to help other people look at the data, we also made one-page data profiles, one for the state as a whole, and then each county as well. That way, if there's one county that was worried about some specific things going on, we could give them that, and they could base some of their decisions off of that. Next slide. So this shows our two major categories. We have health status indicators, which there were 28 of. And then the bottom half, the gold side, is the social determinants of health, which we had 20.
Sorry,
yeah.
Sorry to interrupt.
No, that's okay.
Do you want questions as we go through the presentation? It looks like we've got one in the chat box.
Oh.
The question is, are all 50 indicators used in all 83 of Michigan's counties?
That's a great question. They were all used to help rank, but there are some counties that either don't collect that data or they don't have enough to make it a good number, like enough, I guess you would say, to make it statistically significant. But they were all used to help in the ranking, yes. So all 26 of the social determinants of health, all 28 of the health status indicators. Does that help? Hopefully answer the question.
It does. Juliet, that question was for me, John Barnes. So the ones this is weighted, there's a weighted scale on some of this?
We actually chose not, that's a great question as well. The county health ranking that you find online for Michigan is a weighted scale. Ours is not. We didn't want to weight one thing over another because there's a reason for doing that and a reason not for. We chose not to. We didn't want to say that cancer mortality rate is more important than, let's say, EBLL of, lead levels in children's blood. We didn't want to weight one thing versus another. So all of them are weighted equally. And all measures are used for each county, whether they report as 0 or not statistically significant or not.
Also, to add to that, this is Miguelina. We decided not to weight our measure because there's a lot of literature out there based on the particularly there are a lot of difference in the number of weight that you can assign to some of the indicators. For example, the county health ranking that the Wisconsin and Johnston Foundation does. They assign weights to some of the health indicator, like for the poverty rates, they assign like a 0.4 rate. And assigning those rates may indicate that there's a high need or more importance for those indicators in some of the area. And we wanted to have an overview of our list of indicators and how they are performing in our different service areas, so we might be able to compare the different service area based on those health indicators. And the question that you did, Mr. Barnes, about the different data, the availability of the data for all the county. We recognize that for some of the counties, there were like some issues of reliability and precision in terms of the data because they have a small sample size. So for our overall ranking, we decided to remove those. If the county has some issues with precision of the data, we didn't have the data available for that county. We decided to remove those data for that county, so to avoid overestimation and over representation of a need in a certain area.
Right. And also to address the weighting versus not, when it was all said and done, when we had processed all of our data and ranked everyone, it was remarkably similar to the county health ranking data that you've seen before. And that actually, I mean, I think for Miguelina and I, that was affirming because we saw that it was similar. That means we could replicate it, and made us feel like there was a lot more benefit to us doing it that way. Go ahead, and does anyone have questions about the different indicators that we used, or we can address those at the end too? Miguelina, did you want to go on?
Next slide, please. So we identified eight main health issues in the state after analyzing the 54 health indicators and comparing Michigan versus the national data, and also highlighting the counties with a higher need for each measure. So we wanted to make sure that we were looking at the data not only at the state level, but also highlighting some needs that may be more important for urban area versus a rural area. For example, some of the main health priority issues that we highlighted in our report were the infections and chronic disease in Michigan, the substance abuse and behavioral health, especially drug-related deaths and opioids, especially for urban areas and the southeast side of the state, and health disparity primarily in urban area when we were looking at the data at the ethnicity and race data. But we also found some health disparities in terms of age group and sex in some rural areas. So we also highlighted some of those health disparities throughout the state, and for some of the health indicator when we had the data available. Maternal and infant health, particularly in rural Michigan, that was one of the main issues, especially in terms of access to maternity care in rural area. And people with disability and other vulnerable populations, such as elderly and children, and also some of the socioeconomic factors when Michigan was performing worse than the national rates, or when we saw some type of disparities in terms of at the county level in terms of some of the age group or race, for example, unemployment, poverty, food and housing insecurity, and healthy behavior. And leading causes of death, in particular for heart disease and cancer, Michigan still has 9 of the 10 leading causes of death in Michigan, still higher than the national rate, especially for heart disease and cancer. That they are significantly higher than the national rates. And we have also highlighted some of the top counties with the greatest need in terms of each individual indicator. And the last one is access to healthcare and preventive services. We wanted to highlight some of those needs in urban versus rural area, especially in terms of the population to provider ratios. Next slide, please. And this is one of the main indicators that we use for the shortest destination process, the population to provider ratio. We look at 4 different ratios. The first one is for primary care, the population to primary care provider physician FTE ratio. And we also wanted to know more about maternal and infant health, the OBGYN distribution in the state. So we also calculated the female to OBGYN provider ratio. This is not used for shortest destination because it is part of the primary care physician ratio that we use for the primary care shortest destination. We use MDs and DOs and family practice, general practice, internal medicine, pediatrics, and OBGYN. So we don't have a separate calculation for only maternity care desert in the state. So we wanted to have a better understanding of the distribution of OBGYN in Michigan. And our data showed that there is when we look at the data at the state level, there is an overall abundant supply of provider practicing in Michigan relative to the geographic population in the state. But then when we look at the supply of provider at the county level, that supply is not evenly distributed throughout the state. We had counties with a relatively high population to provider ratio, or no providers identified in that service area. For example, for the psychiatrist population to provider ratio, there were over 20 counties with no psychiatrists identified in their service area. And for the OBGYN distribution, there were approximately the same number, 25 or 26 counties with no OBGYN identified based on our criteria, and also the data that we use in the shortest destination management system. There are different thresholds at the federal level that we use to identify overutilized areas and provider. For example, for primary care, the ratio to identify overutilized providers and area must be greater than 2,000 population to 1 provider, primary care physician. And for dental health, 3,000 dentists to 1 population to 1 dentist. And for mental health, the threshold for the overutilization rate calculation is 20,000 population to one mental health or psychiatrist only. So based on that threshold, we identified that at the state level, our providers are not identified and are not overutilized. But again, at the county level, there's a higher need for providers, especially in rural Michigan. Next slide, please.
Before you go ahead, can you go back, Sarah, to that slide? This is Steve. It was hard for me to understand. Are those designations of 2001, 3001, 20,001, is that a benchmark nationally? Is it independent of metro, micro, rural designation? Where did the ratios come from again?
So based, these are ratios that we use per federal regulations and policy that has been established since the 1970s. We are not able to change that. That has to, if there's any change in the methodology and the criteria that we use for shortage designation for the health professional shortage areas designation or the medically underserved area and population designation, that has to be at the federal level. And this, we use the overutilized ratio to guide us to identify if there's any area in Michigan with any issues in terms of access to care and availability of providers in that area. But the federal regulation does not have any different, it doesn't create like any different population to provider ratio for urban area or rural area. It's the same population to provider ratio threshold that we use for all the type of destination, primary care, dental, and mental health. And they are working in taking comments from the community and different stakeholders to see.
So it sounds like there's updating that should be done at the federal level. And will this work help inform?
I didn't hear the last part.
It would appear if these benchmarks are from the 70s that there's an opportunity for work to be done at the federal level to bring this into the 21st century.
Yeah, and a lot of
Will this help inform them about that sort of thing?
Yeah, and last year, Amber can talk more about that, but last year HRSA requested comments from the community to update or in the future to update as part of the shortage designation modernization process to update some of their criteria, but that is not something that is going to happen soon, anytime soon. It's a process. They have to evaluate those comments and see if they can change their regulations in the future. But they are taking comments, and they were taking comments like last year from different stakeholders, and we submitted comments to HRSA also, so they can update those population to provider ratio, because right now that's one of the main criteria that is affecting the HPSS score for so many rural areas. So many rural areas, even if they have a high need in terms of social determinants of health or providers, because of the way that we calculate the population to provider ratio, that's one of the main criteria that gets you the most point for the HPSS score. They still have a lower HPSS score because of that calculation. Might not be the best way to calculate the need for some of the rural area because of the low density in those areas.
Thank you.
Next slide, please. This is an overview of how we calculated our rank process. It's similar to the county health ranking, but without the weighting system. The first step of our ranking process was the standardization process. This is a process of putting different variables on the same scale to allow comparison and assessment of health needs across the service area. Because we have different measures, we had rates, we have percentages, we have ratios. So we wanted to make sure that we were using the same scale to compare our different service areas. So the first step was the standardization process. Then we created an aggregated CIS score for all our counties and also for the state, and created an overall ranking and then by category and highlighted the rural versus urban needs. And the final step was the county ranking, higher C-score graded the need in that area. And we created the one-page data profiles for the top county, but also that the one-page data profile is available now for the 83 county, because we wanted to make sure that this report is not only used for our PCO efforts, for the primary care effort, but it can serve as a tool, a reliable tool of information for our community. So there are many organizations that can be working on grant application. They can request our provider data for the number of providers in their county, or an overview of their county through the one-page data profiles. And the last step was creating the color-coded map for better visualization of the needs across the state. Next slide, please.
So this is our results. This is the whole statewide, not broken up into the two different categories, but all of them together. And the highest scores are the dark orange, or it might kind of show up red depending on your screen. And we have 3 out of 5 are rural. And then we've got Wayne and Genesee as our 2 urban that ranked as the highest needs. And then the lowest ones are mostly urban, kind of flipped. And we've got Oakland, Leelanau, Washtenaw, Ottawa, Livingston on those. So I don't think anyone was surprised when we found those, but that's our highest and the lowest. And then on the right side of that slide, you can see a visual representation of where those highest needs areas are. And then the lightest green is obviously the ones with the lowest score. Next slide, please. This is a breakdown of the 2 categories. So you can see the health status ranking and the top 5 and lowest score 5. And then on the bottom, you can see the same for the social determinants of health, the top 5 and bottom 5, as well as the different categories within those are listed after. And then the next slide is a little easier to see it per county. Yeah, here we go. So good visualization if you're one of those type of learners like I am. There are a few counties that are listed as high need in both categories. So you'll see Wayne, Calhoun, Clare is listed on both of those. But then there are a couple that are different, and that just shows you how some of the data can help us see what areas are struggling and in which ways. Next slide.
So we also identified as part of our process some of the main barriers to care. We consulted different PCO partners and stakeholders, and not only about the needs assessment structure and methodology and the content and the number of health indicators. They provided some recommendation for what indicators to use, and the data sources and other related topics, but we also conducted a literature review and research to identify by analyzing different health needs assessment at the county, at the community level or regional level, the local health department level, to identify some of the main challenges or priorities for the providers, and also at the state level for some of the healthcare facilities. And the first barrier that we identified was the shortage areas, the medically underserved area and population, the health workforce shortages in the state. For example, for primary care, there is approximately 2.8 million underserved residents in Michigan. There is a need of 546 additional practitioners to remove all of our primary care designations in the state. In the case of dental health, there is approximately 1.5 million underserved residents in the state, and approximately there is a need of 350 providers to remove dental health HIPAA. For mental health, we identified that there is a approximately 40% of our population is underserved in terms of mental health services or resources, and there is a need of 207 providers to remove mental health HIPSA. And the second barrier to care is the healthcare safety net locations in the state and the access to healthcare in rural Michigan, especially some rural hospital closure or rural hospitals that are at risk of closure, and limited access to maternity care in rural area. We also highlighted the health workforce projections and residency and fellowship capacity in the state, and also that there is a need to assess the capacity of Michigan future healthcare workforce and to address the health professional shortage and maldistribution of providers in urban versus rural area. And the other barrier to care that we highlighted in our report is the transportation infrastructure and the other challenges, such as Michigan geographic and its unique challenges in terms of access to public transportation and travel times, comparing rural versus urban area, infrastructure status and road conditions of the state due to the weather or other reasons. And the last barrier to care that we included for this needs assessment was the political and economic climate. This is a new one that we wanted to include, especially we highlighted the Medicaid work requirement law back in the beginning of 2020. That was a main issue for our providers in the healthcare facility and the population. Even though a federal judge stopped the implementation and enforcement of the work rules, that was one of their main concerns in terms of the Medicaid work requirement law. We also talk about the opioid and prescription drug epidemic in Michigan and provided an update for the clean water crisis of water crisis in the state. Back in 2016, our needs assessment in 2016, Genesee County was ranked as the county with the greatest need because of mainly because of the clean water crisis and the challenges that the population was having during that time. And we wanted to provide an update and some of the response action that MDHHS and some local community has done in the past years to address the clean water crisis. And we also talk about the COVID-19 impact on healthcare delivery and the access to telemedicine and telehealth reimbursement. We wanted to highlight how COVID-19 is affecting not only the population and the mental health and the also economic challenges in terms of COVID-19. And how and the access to telemedicine and that could be a challenge for so many population if they don't have a good internet access, and especially elderly population and other minorities that don't have access to telemedicine because of social determinants of health or poverty. Next slide, please.
Magdalena, there's a question in the chat box. Steve wants to know
John.
if in the workforce shortage, if APNs and PAs are included or excluded in certain.
So for short destination, for the primary care destination, we don't include a nurse practitioners or physician assistant. We also exclude some providers if there are if they don't provide direct primary care. They are only solely involved in administration, teaching, research. So those providers are also excluded from the calculation of the population to provider ratio. So we don't include a nurse practitioners or physician assistant either. Only physicians in 4 of this specialty that I mentioned: general and family practice, internal medicine, pediatrics, and OBGYN for primary care.
And then I just have a question that on hospital closures, we haven't had a hospital close since Sheboygan did back in, I think, about 2013 or 14. So, but you did mention hospitals in distress, financial distress. Inside the report, does it state the indicators or the methodology, the math you're using to come to identify rural hospitals in distress?
So we based our analysis for the barriers to care, especially for that one of hospital closure, to some literature review. there was a report, I forgot the name of the organization that published it, but they conducted an analysis of the hospital at the national level that are at risk of closures in the state. And Michigan ranked 9 as in terms of risk of hospital closure. I know that there's been more than 10 years that we haven't had like any hospital closure, but we oh, that's the report. Thank you, Crystal. That's the
All right, thank you. It's footnoted. Good. I'll look it up. Thank you.
but we wanted to highlight the risk, how Michigan is ranking in terms of risk of hospital closure, and also financially. Not because a hospital is still working, that doesn't mean that they didn't have to cut down some of their essential services. For example, maternity care access, obstetric care, and we heard a lot about that going on in rural Michigan. Next slide, please.
So this kind of shows where we go from here. We're going to continue to update the shortage designations for each area and apply for any governor's exceptions that we need. Migalina is highly involved in that part. And we also want to continue strengthening current partnerships we have with other areas of MDHHS, plus the Center for Rural Health and our tribal liaison. But we're also looking for new collaborations. Anyone that can benefit from our report, as well as help inform us going forward on updating things. We want to reduce any barriers to primary health care by using our current programs. So an example of that is the Michigan State Loan Repayment Program. We will form priorities based on areas of need. So the OBGYNs get priority because we desperately want them to stay in Michigan and help us out instead of going elsewhere. And also when Genesee, the issue with the lead levels was discovered, we moved that priority up as well. That's an example of how we let it inform our current programs. And we want to help current healthcare facilities expand access. Our free clinic program helps provide some funding for some of our smaller free clinics across the state. And going forward, we want to do interviews and surveys to help us get better data and more idea of what's going on around. Example of that is a lot of the statistics and data for homeless care across the state. It's not very consistent data. It's a very hard data set to get because of the nature of homeless. And we found ways to maybe interview some of the housing specialists and coordinators across the state. We're also implementing a retention survey for any of our Michigan State Loan Repayment Program providers to see if they're staying in their current placements, if they're staying in Michigan, and if they're satisfied at their placements. So that is where we're moving from here. Are there any questions moving forward?
This is Hunter. I do have a quick question. As far as other partners to look at and resources that may be needed, I know a lot of the key mental health programs have really suffered and been understaffed, and that I think is a part of the exposure from the behavioral mental health needs in a lot of the areas, especially in rural areas.
Mm-hmm.
We do have a difficult time recruiting providers, and kind of going through all that aspect helps support those needs from those patients and community members. Is there any opportunity there that we could potentially expand out either, the hospital-based mental community health services and or the outside agencies?
I think we'd love to establish like an open communication with that area and to see what other ways that we can help support that. Currently, I mean, Amber can probably say which areas of our program currently support that. We do accept some MSWs in our Michigan State Loan Repayment Program, and I know other areas do as well, and help them incentivize kind of them staying in Michigan and staying in our areas. But we would love to make more connections and foster more communication towards that effort.
Great, thank you.
And we will be happy to send out our full report, which includes the one-page profiles at the end, so people can look, organizations can look county by county and see where the need is and whether it's something that we can work towards resolving some of those needs or putting effort towards them. So Miguelina, have we already sent them the full report?
I think that Amber, did you send the final report? But
I,
I,
the reports, oh, sorry, go on.
I think they mentioned at the beginning that they had the report available, but I don't know if it is the final one that we submitted recently with the 83 county data profiles.
Okay, with that, we do have it available, so if that would be beneficial, we'd love to share it. Are there any other questions that we can help answer for this process? I know we answered some along the way.
I just want to know, we did send the report, and to be honest, I'm not sure if it did have all of the county profiles, but I'll connect with you following this meeting and we can get that sent out with the meeting follow-up.
Perfect.
Well, thank you both for a comprehensive report and presentation. And we do have that 83-page document, I believe. I didn't wade through the whole thing yet.
That's okay. It is long and it has some great information. So I hope you do find it beneficial, and thanks for having us present. We always love to make new connections in the communities.
Well, thank you. All right, any other questions? Not hearing any. You're welcome to stay if you like, or you can sign off. It's entirely up to you.
All right. Thanks very much. Thanks for having us.
Thank you for
Thank
the
you.
invitation. Bye-bye.
Bye. Sarah,